want to sincerely thank you both for joining us. We have Richard Corbridge is going to give us a presentation, and then following on from that, Professor Richard Greene is going to join us as a panelist to aid some discussion topics that may come up and to bring the clinical perspective, and also Richard Greene worked very much in the space as well. So what I might do is formally introduce Richard Corbridge, if that's okay, and then at the end of the talk, Richard Greene, I will introduce you formally, if that's okay.
Fine, thanks.
Great, thanks. So I just switch off your microphone, and there, Richard Greene, great stuff. So thanks again to everybody who has joined us. I'm delighted to say that today's webinar has proven extremely popular with nearly our highest number of registrations to date, which is great. So it just shows how topical this issue is. Firstly, sincere thanks to Richard Corbridge for taking your time today in delivering this webinar, Richard. For all of those that are attending, this webinar is being recorded, and we will have this up on our website this afternoon in case you've missed parts of it or want to review it or share it with your colleagues. So by way of a formal introduction to Richard Corbridge, he's an expert in healthcare strategy and technology, recognised by his industry globally. Since 2014, Richard has been the Chief Information Officer for the Health Service Executive here in Ireland and the Chief Executive Officer for eHealth Ireland. He has been involved in the health and clinical research information sectors, leading various informatics delivery functions since the late 90s. Richard has a passion for business change and benefits management in health, and very much insists on a focus on engagement and benefits being brought to the technology implementation. Richard has led the delivery of a wide range of systems and process to aid the provision of healthcare and research. These range from the first primary care messaging system in the NHS to a health and social care single assessment process within a care trust and modernisation of the information systems infrastructure for the delivery of clinical research throughout England. In 2015, Richard was named the 5th most influential CIO in Europe by CIO magazine, and he was listed by Computer Weekly as a rising star of the IT industry, where they specifically called out the speed by which the health system in Ireland was moving towards adoption of an eHealth fabric under his guidance. Richard was also named by the Huffington Post as one of the most social CIOs, and those of you that follow Richard on Twitter, like ourselves, can see that he's regularly updating his tweets. And if you want to follow Richard, the details there are on the front slide, but it's at R1 Chartatron. So great, I'm going to pass over the controls to you now, Richard, to give the presentation. And for those that are joining in, if you want to pitch your questions throughout the presentation using the Q&A facility, and I will direct these questions. To both Richard Greene and Richard Corbridge at the end, and I'll formally introduce Richard Greene at the end of the presentation. So thanks. Over to you, Richard.
Cheers, Sandra. Thank you very much. Okay, as Sandra mentioned, the concept of the next half an hour or so is to give you a bit of a flavour of what's happening across eHealth Ireland, what our direction of travel is, give you a chance to see some things that are being done so that when it comes to the Q&A, when it comes to understanding where we're going, we get a view of what's in place. One of the things I would say is that there isn't a digital fabric being created for specifically clinical research. It is absolutely around empowering a digital solution across the different ways health is delivered. But hopefully we'll touch on different areas around research, around that piece as we go through. So a few scene setting pieces first. One of the things we've been talking about recently is imagine healthcare generally being like an Airways. Bit of an odd thing to suggest, but I guess Ireland has quite a reputation for delivering different innovations around the way people travel through the air. One of the things that you would never do or start to understand that you need to do when flying an aeroplane, though, is absolutely relating to how it works, how it flies, what the resources are that are in place. So if you think about healthcare, trying to make sure that before we even begin to do what we need to do in healthcare, we start to make sure we have in place the ability to have the resources and funding that need to be in place. It makes sure that we have the right number of people, we have the right number of funding. You also wouldn't start to try and fly a plane without actually having an ability to understand the business intelligence, as we call it, an instrument panel. What is the data that we've got? How do we make that work? How do we put that in place? And that's really important to all of us as we start to make sure that we can understand the data coming out of the health system. With that data, we allow ourselves to be communicated to. We turn information into insights. We have communications that enable us to fly healthcare airways. And then obviously keeping information safe and the security around an airport is ultimately important to actually enabling flight and healthcare to actually be something that we can do. So this becomes a really big part of where we're trying to go and what we're trying to do. And generally, when you think of the innovations in flying in recent times, I mean, now when you look at an airport, less than 50% of people have actually got a paper ticket anymore. They're using their phone as their ticket. They're using their mobile devices, their entire connectivity to how they fly and what they do in the air. And that to us starts to indicate a direction of travel for maybe where healthcare would go. If you consider the timelines we've got to deliver health, JFK famously stood up and said within a decade he would put a man on the moon. And to us, we compare some of this to actually putting a man on the moon. And he took just over 8 years to put the first man to land on the moon. To us, we've got 5 years to do eHealth. We have the eHealth Island strategy. We have a knowledge and information plan that takes us to 2020. What we need to be very careful of in that space, though, is that we don't start to consider that when we get there, it's done. Now we've started to invest in eHealth. Now we've started to put technology in place across healthcare. That means that this now is a continual investment. This now continues to grow, continues to release efficiencies, make the system safer, empower clinicians and patients to communicate. But it isn't a hit the date, finish delivering the things we've said, and then walk away for another 10 years and come back later to do it again. It's very much an evolution. And that's been an important part of what we've tried to do in 2015. This isn't an attempt to say, here's a strategy, here's a plan, give me some money, give me some bodies, and I'll come back in 5 years with everything done. This needs to be something that evolves over time, and we've taken that strategy very much. I mentioned already about information and turning information into insight for patients and for clinicians alike. In the health systems across the world, we collect a lot of information. We do that without actually thinking through the impact on healthcare always. We still collect in Ireland carbon paper copies of ambulance reports, of system reports where patients are moving through the system. And that's data that we don't even get and turn into information. One of the ambitions of the Knowledge and Information Plan is absolutely to start to consider how we change that current curve. How do we actually impact upon the difference in care through access to information? We have this common phrase around turning data into information so clinicians and patients alike can begin to get insight. How do we make clinicians fans of data and technology? By changing that curve, by making sure that without actually collecting more information, without making clinicians do more work with technology and data, we can change the way the information is used to provide a better quality of care, more efficient care system, and empower the patient to be involved in care decisions based on the information they have. Many organizations come to talk to us at the moment around analytics and information that can be got out of health data. We're fond of pointing out to the Googles and Microsofts of this world that actually health analytics came from healthcare. It didn't come from the big business organizations that are now looking at how they can help health. It came from us understanding how to deliver better care to patients. Famously, Dr. John Snow in 1854 believed that cholera was being transmitted in London from a water pump. The government at the time in London didn't agree with him, believed that cholera was being spread in London through people arriving on ships. Dr. John Snow went with a list of everybody who died, showed the government that this was the situation that they had, but the government couldn't understand that data, just a list of people. They disagreed with him. So what Dr. John Snow then did was went away and mapped onto a geography map where the people were dying, and it showed quite clearly that it was around the water pump. Dr. John Snow was then given permission to take the handle off that water pump and take that as a trial, as an actual clinical trial, one of the first examples of a clinical trial, allowing us to understand the impact of taking that handle off there and therefore seeing that people stopped having cholera. Even today in Soho, that handle is still in the Dr. John Snow pub, and people can go and see the birth of healthcare analytics in the whole system. And this is something that we're now working hard to put into place. That where we collect information, we collect it for the purposes of improving healthcare. Where we have insight from information, we share that and empower patients. In the spring of last year, we published the Knowledge and Information Plan. This is a plan that sits on top of eHealth Island, the strategy, and allows us to truly understand exactly where we are deploying systems. Understand the plan, the resources required, the funding to do it, and the benefits we expect to get. We split our plan up into 5 pillars. Understanding how we enable care differently. A very big project on the electronic health records. An electronic health record will be shared across the whole of Ireland. Allowing information to share across different settings, allowing to build that insight I've spoken about from information. And importantly, those support systems in place. None of that can be actually done without creating good clinical information governance and without actually starting to understand the transformation that's required. Information governance and clinical governance are imperative to the use of a digital fabric in health. Without information governance, understanding a legitimate relationship, sharing and accessing information, protecting a patient's right around digital information. Those things need to be in place acutely across our system that becomes over the next year, 18 months. Things like privacy impact assessment published last week around the individual health identifier become crucial to us all going on a journey to understand now we have digital information. What difference does it make to how healthcare is provided? 2015 was a huge amount to put through. Probably the biggest around the individual health identifier. Sensitive hospitals now able to accept an e-referral, something that Richard was involved in at its very early stages. When I joined the organisation in December of 14, people came to see me to say they'd run a very successful pilot in Corbridge around electronic referrals. Now the pilot had finished, they wanted to do the next piece of work. We set ourselves our own standards and our own direction of travel around this. This wasn't a target provided by the department or by Minister's office. This was the HSE saying it could see the benefits, efficiencies and safety gains in doing e-referral. And in 12 months, we will have completed e-referral for the whole country. 5% of GP practices will be able to electronically refer, and we will ask patients next time they're in the GP being referred into hospital to ask to be electronically referred. So the numbers matter as a huge amount. We're now starting to understand how we've moved forward. Simple things like creating a Island website, onto more complicated things like moving the information for the hospital and the eHealth Island in place. 2015 was very much putting those building blocks in place to allow us to do that. That was against 2 pieces of information. We in eHealth Island and the HSE's IT team want to be transparent in how we deliver technology. We want to understand, people start to understand an investment in technology is an investment in healthcare. You wouldn't build a hospital by putting water and electricity into its plans. So let's not build a health system without putting technology into its plans and how we do that. In doing that, we want to be transparent in how we get but agile as well. So every day that we are doing this isn't a big plan to the end in 2020. It's a big plan to deliver something new and different, innovative, and that makes a difference each day, each week, each month. To slowly build our understanding of what technology is and start to put in place how we use technology to deliver healthcare. The picture on the slide now is extremely important to us. It puts the patient at the center of what we do. We understand the different ways delivered across the system. We understand how technology can start to join up this. But actually enabling the patient to be at the center of everything we do becomes a massively important part to us. Imagine a world where the patient was the owner of information about them, where the patient became the person who could control the digital information that is held about them through healthcare, and they can decide who can see what, where, and when. Maybe a grand desire to get to, but something that we'd like to understand what the impact of that will be. How can we get to the point where a patient is truly enabled to be at the center of their care by the system we provide around them? Acutely important to where we go. The next slide is a difficult slide. It's our blueprint for an electronic health record. Blown up large, this has been validated by over 25 suppliers from across the world who've come to Ireland to say, okay, if this is your plan for an electronic health record, let us validate it against other countries, other systems, and other ways of delivering a solution. Each of those boxes needs to have some kind of digital solution that joins up the electronic health record across the system. This isn't an EHR for hospitals. This isn't just for primary care. This is an EHR that allows the physical nature of care that is delivered to be joined up across the system. It's also not one big system or big solution from one supplier. It's become very important and apparent to us that suppliers across the world who can deliver these type of systems are actually unlikely to have a single solution that fits all, that could deliver a single electronic health record. So what we start to do with our business case, which will be available in the first quarter of this year, is describe what an electronic health record that is integrated across care settings looks like, how that would work, how that would be built, and how that could be delivered across our system. The before and after picture of an electronic health record for a whole country is a very different and changing picture though. The business case we're building for an electronic health record is intrinsic to the delivery of the National Children's Hospital. Is a big part of actually making a hospital be born digital, as people are fond of describing. And therefore moving from a situation where this is the health record capabilities of a major hospital in Ireland, where people come into this room urgently looking for a file that can be on the top shelf. A single post-it on a page 140 is the piece of information that a clinician has asked his secretary to run upstairs and find within the hospital. Imagine how the security is managed of all that information in that space. And imagine how hard it is to actually pull the file that's needed and get it to the clinician that wishes to deliver care as efficiently and carefully as he possibly can. It means that this thing becomes hugely important to the way information is managed at the moment. The elastic band is our security. It delivers data quality, it provides information governance and keeps all the data together. And an electronic health record, the business case for that, enables us to actually move away from this simple piece of plastic to being our way to deliver such intrinsic parts to how we have information in the health system. A hugely important piece as we move forward. If you start to look in primary care in particular, there's a journey that has been started, where we can actually start to understand the different things that we're doing and how we deliver those systems. We have already put in HealthLink, a solution that securely connects primary care to secondary care for structured electronic information. We can allow discharge notes, reports from labs, the referral to move over this HealthLink solution. HealthMail is a secure communications solution for clinicians so they can talk about patient information securely, so they can be sure that that information is only going from a health professional to a health professional. We mentioned already the health referral. Cancer and general referrals are now in national rollout, and the ability to define other therapeutic-specific referrals is now available. The Health Identifier was created in the second week of September as a proof of concept, and will roll through over the next 2 quarters to actually deliver the full, robust individual health identifier connected to systems across the whole of Ireland. All of those 4 boxes give us the ability to then move to the next 4 areas, where we can start to consider what a health summary could look like in Ireland. How could we start to make some summary information available in an emergency department? Today, as we're here doing this WebEx, there are 2 pilots going on across Ireland to understand what electronic prescribing from primary care to the community pharmacist could look like. 2 very different pilots. 2 pilots that consider different solutions both for the pharmacist and for the clinician at the GPN. But most importantly, even different for how the patient interacts. Will a patient use their mobile phone to communicate with a pharmacist to say, please have my drugs ready, I'm on my way? Or would the patient prefer to still have a piece of paper with a barcode on that enables them to get their prescription? The way we're working with those 2 different pilots is to do an evaluation of them that will then inform how we move forward and what we deliver next. In 2016, the HSE, working with a number of organisations, will re-accredit the GP practice systems that are in place. How that works is still being developed, but currently those systems are bought and paid for by GPs, and the HSE needs to be able to provide some assistance in that space. If we expect those GP systems to do the individual health identifier, to have eReferral in them, then we need to understand how we accredit those systems and how we fund those systems to be in place. And last but not least on that list, if we can do eReferral, then we should be able to do a discharge note as well. And many, many clinicians tell us that is the most important piece on that page in front of you to move to next. But doing all this after the game of the weekend is very much like trying to play rugby with 4 teams on the pitch. We need to ensure that we keep and allow patient and public choice around health records, so that there is choice about who they share with, how they share, and where the information is. We need to thoroughly make sure that we protect Ireland commercially. We must not end up in a situation that other jurisdictions have ended up, where they have to deploy a system that is perhaps not fit for purpose, or where, even worse, they don't deploy systems but still have to pay for it. Data protection and policy around data protection is intrinsic to the delivery of what we do. Currently, our use of the Data Protection Act is how we manage information completely across our system. Is there a possibility to move to a health policy around how we use data protection in the Act? Is something that we need to understand. And then allowing us to be both innovative at a local level and nationally standardized. Two words that perhaps don't sit well together, but two areas that mean that we need to move in the same direction to actually allow systems to be connected are important to us. I mentioned already the individual health identifier, a huge building block for what we do and how we get there. September 2015, the proof of concept went live. 4.9 million individual health identifiers created in a proof of concept solution. Last week, Privacy Impact Assessment published for public comment in draft, the first few chapters of which focus entirely on the individual health identifier, allowing anybody in Ireland to come forward and pass comment on the impact of having an individual health identifier. Remembering this is around health identity, not health records at this point in time, a very specific piece. That feedback will allow us to tailor what we do next and allow us to move towards some sites going live with a proof of concept in July. Those sites would be 35 GP practices who have volunteered, the epilepsy electronic health record, and the electronic medical record that's within Laura Lynn Hospice here in Dublin. Those referrals continue to rise. The blip in December is due to normal situations, but actually pleased that every week we're seeing the last small number of hospitals begin to actually take the electronic health e-referral. And that means that we can start to allow all patients across the country to refer, meaning that they see the referral that has landed in the hospital before they leave the GP practice. When we looked at referrals, we did an audit with an independent organisation to understand how big the referral process is currently. And the referral letter, on average, touches 18 pairs of hands. An electronic referral lands in the hospital before the patient has left the GP practice, and they can be assured that it has got to the hospital that they've been referred into. A huge leap forward. I guess just as importantly, though, is the GP impression of e-referrals. We hear from GPs who have referred as many as 8 patients on the very first day that a system has gone live across their geography. So far, we're seeing GP practices are really enjoying using the e-referral process, removing the need to print out a letter, find a stamp, put it in an envelope, pass it into the system, keep checking to make sure it's got there. A really positive step to joining up care. Throughout December and January, we ran a public consultation around what an electronic health record would look like in Ireland. We asked the public generally to come forward and pass judgment against a series of questions about what an EHR would be, what the consent process should be, what the security levels should be, and how that should work. It's really heartwarming to see the number of responses and the positivity around electronic health records. Very much largely indicating that the people of Ireland thought that this existed already, and now they know it doesn't, want to know how quickly Ireland can actually make an electronic health record be in place. Building an electronic health record will take time. The first full hospital with an electronic health record in place will be National Children's Hospital in 2019. There will be sites that start electronic health records before that. What we have done, though, in this year is created 3 projects that we call the Lighthouse Projects. These projects are very much focused in specific therapeutic areas, allow us to understand what we can do with information to help the delivery of care. Epilepsy is the first one. Delivering a mobile to patients, allowing patient analysis to be done, delivering 2 images in GP, putting the individual health identifier, and perhaps most exciting, sequencing the genome of a number of patients in 2016, so that we can tell immediately the type of epilepsy that is present, target the right drugs, and genuinely save not just money, but lives of patients with epilepsy. Haemophilia already has an excellent solution deployed to allow effectively the supply and management of treatment patients into their home. A solution that's been around some time, a solution that needs to be updated. We will work with the haemophilia associations and clinicians to integrate that current system into patient administration systems. We'll look to ensure how we make that open source so that other organizations with correct security can start to access that information and build applications that are for the benefit of patients and clinicians alike. We'll start to understand what applications for patients are, how we can enhance what's there already. Again, putting the individual health identifier into that solution and continue to build towards a secure clinical communicator, where a patient can start to actually speak to their clinician securely, either over voice or over text messages, and get advice and guidance, even adding to the electronic health record. And last but not least, is bipolar disorder. Understanding how and what can be done in an area that so far we have seen no innovation from a technology point of view. Would a patient with bipolar disorder benefit from securely, clinically communicating with a clinician when they felt that they needed to? How do we integrate that information into different settings? What sort of clinical support would benefit a patient? Huge pieces of work in an area with such a small amount of innovation and technology being placed in there already. A chance for Ireland really to understand what it can do in 3 different areas. Those Lighthouse projects have very much been chosen to enable us to understand how and what it is that we can do. So a really different way of going about this. As I mentioned, we already have some work done in haemophilia. You'll see on the screen there the devices and solutions that have been deployed from St. James's, where a patient can actually barcode scan their treatment into the fridge in the home. Allows that to be recalled very quickly, allows it to be added to information about them. By adding to this, by putting more information into the system, by linking it to the patient administration system, we deliver more efficient and safer care. By allowing a solution similar to that deployed by the Heartbeat Trust, where we can start to see images taken from an epilepsy patient. So GPs can start to understand the different ways care can be delivered and start to help diagnosis without having to send the patient into hospital to have that scan done. And also by therefore taking the sequencing of the genome that I mentioned. It now costs less than $200 to sequence the genome. We spend currently €5 million trying different drugs every year for newly diagnosed epilepsy patients. Therefore, the difference in just sheer cost, never mind the impact on the patient and the quality of life, is significant in that space. We're also pleased to announce a couple of weeks ago that the HSE would take part in the NDRC's Future Health Programme, a programme of innovation where organisations come together with bright new ideas, where over a 6-week programme they start to build those ideas into a solution that could be made, where the winner receives assistance in how they take forward their idea. The NDRC has had phenomenal success in accessing new organisations in need of help to actually come forward with their great idea and apply that into healthcare. So from the beginning of Future Health this year, there will be HSE clinicians available, IT people available, ability to access dummy data, ability to access stubbed systems, so that the NDRC programme can really start to deliver against a HSE platform, not just a healthcare anywhere platform. All of this takes us to a different way of innovating, a different way of thinking. In 1800, it used to take 6 hours to earn enough money to get 1 hour of reading at night, 1 hour of learning after work at night. That changed, but not very quickly. By 2014, half a second to earn 1 hour's worth of reading light. An impressive jump, but such a long time to go from 6 hours to half a second. Because innovation happened horizontally. Ireland finds itself in a unique position. It can vertically grow. It can change the way it innovates. One of the phrases we try not to use too much, because asking for investment in magic is not always going to give people a view of where we go, is just that. Is start to understand how vertical growth can change the way that we deliver healthcare in Ireland. How actually enabling a digital fabric to come forward will change how we bring those solutions together. Hopefully that's been a useful half an hour, a whistle-stop tour of where we are and where our direction is. I'll hand back to Sandra now.
Great. Thank you so much, Richard.
Some comments and some questions.
Great. Thank you so much, Richard. Can you hear me okay? Hello, Richard.
You can? Yes.
You can hear me?
Yeah, can hear you. Yes, yes.
Hello? Oh, great. Sorry. I think the connection is dropped a little bit during the presentation. So, so apologies for the interruptions in the connection, but hopefully everybody was able to follow that. And so, first of all, before we go into the Q&A session, I'd just like to give a formal introduction to Professor Richard Greene, who joined us as a panelist for this webinar, and just to add another dimension to what Richard Corbridge has just outlined. So if I could just take a minute to introduce Richard. He's a graduate of TCD and gained much of his clinical experience in the CUMH Hospital in Dublin. In 1999, he took up a position as a fellow in maternal fetal medicine in Thomas Jefferson University Hospital, Philadelphia in the US. And on his return to Ireland in 2001, he joined UCC as a senior lecturer and consultant in obstetrics and gynecology, and took up his current post as Director of the National Perinatal Epidemiology Centre and Professor of Clinical Obstetrics in UCC in 2007. Professor Greene was instrumental in commissioning and establishing the new maternity services at CUMH and continues to maintain a senior management position within the service. His research interests include maternal fetal medicine, epidemiology, health services research incorporating risk management, quality of service and translational research. Specifically, his future interests include developing the work of the NPEC as a national service with the aim to provide clinical services for Irish patients. Professor Greene is clinical lead in obstetrics for the development of a single electronic medical record for all maternity hospitals, the maternal newborn clinical management system. So, Richard Greene, thanks very much for your patience there. So, I suppose to start, maybe if we just want to see if you have anything to add to what Richard Corbridge just outlined.
No, I mean, I've heard Richard talk a few times, and it's great to actually see it again and again, because every time you see it, you begin to see that the potential of the building blocks that we're all talking about. And I think that to me is the potential magic, is that we have these opportunities to interface tons of different ways of doing things. And he did mention the patient, and I think it's very easy to get excited about everything, but I think all of this should absolutely continue to center on the patient, and the sooner we develop systems where the patient is completely interactive and has complete power, I think the better we will do as clinicians in the care of those patients.
Great. So just to those that are attending at the webinar, feel free to pitch some of your questions to both Richards. You can do this using the Q&A facility, and if you type them in there, I'll be able to field the questions to our presenters today. So just while people are putting their thinking hats on, I was just wondering, Richard Corbridge, you mentioned about the survey, the eHealth survey that you sent out, and you mentioned about a positive reaction with the survey with regards to involvement of patients. Was there anything, now you probably haven't gone through all of the results of the survey, but I was just wondering, was there anything that particularly surprised you, or was there anything that maybe has sent you in a slightly different direction when you fielded that survey, or have you got all the data from it as yet?
Yeah, so I think one of the most interesting parts is people's willingness to share information when they can see the good that it is going to bring them. So we worry an awful lot around risk and around making sure, and rightly so, making sure information is carefully looked after, only the right people can see information. And one of the common themes that was coming, particularly from public rather than clinicians, was actually, if I am assured once that this information is for clinical purposes, and actually I'm kind of happy that people share this information about me for the good of my clinical care. There may be some pieces of information I don't want to have shared, but as long as I'm in control of that, I'd much prefer clinicians to have access to that information than them not. I think there's a real surprise that the state of the nation, from a want of a better way of putting it now, around clinical information being digitally available and how little is there already. So that was interesting to understand.
Oh yeah, great. Great. And then just coming from our own hat here with the clinical trial area, I was just wondering, so how easy would it be for we say getting consent for patients? Is that being considered when you're developing this system with regards to taking part in the clinical trial? Is that something that's being developed in tandem with what's going on at the minute, or is it something that might be considered later? So, for example, when you want to consent with a primary care patient to a particular trial, looking at if you can do this electronically, it's obviously going to lead to maybe better recruitment and retention. Is there anything around that you could add? I would pitch that to both Richards, actually, if you have any thoughts around that.
Richard Greene here.
So from what
Hello?
Hello, Richard Greene.
Sorry,
you want me to go ahead, Sandra?
Hello, I think we have a sound issue. I might pitch that to Richard Greene, if that's okay.
Yeah, Sandra, can you hear me now?
I can hear you now, yeah.
Basically, one of the things I suppose that's interesting in the maternal newborn system, which is going to go initially go live in Cork this year and to roll out to all 19 units, 4 of them probably in 2016 and then the rest over the following 2 years. One of the things that we've built into that, in fact, is the component, the solution is called Power Trials within the Millennium system that we're using. But that actually is to allow people who are doing research to actually document the research on the system, so that if I'm a clinician and a patient is actually meeting the criteria to join a trial or whatever, that actually I will get informed of that. And I'll know exactly who to contact about it and all the rest of it. The trials group will still have to do the work of consent and all the rest of it. But there is that component. And in fact, there's another component that we did actually put forward the idea to people in the HRB that actually acts as, if you like, the type of kind of, but basically it allows all the clinical data and that required DCF or whatever to be pulled out of it. Now that isn't built into the system we're doing, but definitely we have considered this, and I think most clinical systems will have to consider how we incorporate research and stuff into it. But that's just an example of it is already being considered.
Oh, great! Thanks, Richard Greene. Richard Corbridge, do you want to come in on that point?
Yeah, so one of the things we've built as an aside to the individual health identifier, it's not part of the individual health identifier, is the ability in the future to record consent for information to be used for clinical research purposes. And we've done that entirely as a technical piece of work. This isn't policy yet, this isn't being built in that way. It's entirely a thing that could be used in the future, so that patients could be asked once if they'd be willing to have their information shared for clinical research purposes, and by giving that consent once, allow us to actually have that in place just once across the whole piece. So I hope that we can start to understand how we could make best use of that in the future.
Great, thanks. So we just have some questions from our webinar attendees. So I'll just call out the first one here from Kevin Balanda. He says, thanks very much for an excellent presentation. I work in public health. Can you speak about how you see this interfacing with other population health information, such as Healthy Ireland surveys or longitudinal surveys? So perhaps Richard Corbridge, do you want to come in on that?
Yeah, absolutely. One of the things that we've been tasked with doing at the moment is trying to put in place a single information service solution across health in Ireland. It's important that the phrase I use there is across health. It's not HSE, voluntary, public, hospitals. It's how do we put a single solution where health information can be brought together and then through and with consent, joined information, and allow us to truly deliver an efficient and safe healthcare system built on information from the data that is already there. I guess this is the most frustrating part from clinicians around this space, is a fear that we're going to start collecting and therefore asking them to collect more data. And actually that isn't the case. We have the ability through an electronic health record, through eReferrals, through the individual health identifier, with patients and clinicians' consent to start to join information together and give us a really good basis for actually creating population health.
Great, thanks. And Richard Greene, is there any, from the maternity services side, does anything like that spring to mind that maybe should be linked in better?
Well, I think that the reality of electronic health records, if they're put together reasonably well, and people do have to start thinking about not what's coming out the other end, but what's actually going in at a very clinical level. But I think that there are an awful lot of questions we will never answer because it's difficult, because of the numbers or whatever, through randomized controlled trials and all the rest of it. But I think well put together data and interaction with, as Richard says, across all of health, we could potentially gain enormous insights into some of the things we do that we shouldn't be doing, and some of the things that we should be doing that we're not doing. So I actually think that if you like, the big data of good clinical systems will actually allow us to move the science forward as well as the clinical care forward.
Okay, great, thank you. We have a question here from Brian Cleary. He wants to know, how do we reconcile the need for complete recording of outcomes in research? For example, rare events such as congenital anomalies and data protection patient consent issues. The bias introduced by incomplete voluntary participation may invalidate the research. Perhaps Richard Corbridge, do you want to comment on that?
Yeah, I mean, from a consent point of view, this is one of the reasons why we've looked at creating that consent capability within a central repository rather than in multiple systems. Certainly the NHS fell foul to not having a single solution for doing that and ended up with consent for being involved in clinical research across as many as 16, 17 different systems. And what we're trying to do in Ireland is make sure that we collect consent once, and therefore by doing that can actually apply that to different systems. And as long as the patient has consented, we can then join up where electronic information is about that patient and start to create a more population health-based solution to clinical research. But all of that is absolutely predicated on patient consent and clinical consent to be part of that.
Okay, great. Richard Greene, do you have any comments to that?
No, I think it comes back to that. I mean, I must say the general feeling I get from patients is exactly as Richard has said already. The majority of patients within certain criteria are very, very happy for their information to be used if it's going to help. Very often you'll hear the word if it's going to help somebody else, and I think that that's the kind of altruistic nature of things with respect to information. So, but we have to absolutely recognise that we should have their consent. But I think an awful lot of people are very happy. I mean, the Danes have been very successful at this, and they're a lot less worried than we are about consent per se, because the population expect that the information will be used appropriately and very often anonymously, but that can give you an enormous amount of valuable clinical output.
Great, thank you. We have another question here specifically for Richard Corbridge. This is from Kieran Fury. Is the universal patient identifier being retrofitted into existing data that the healthcare pricing office is collecting with regards to activity-based funding? It strikes me that there is an overlap between what the HPO have already done. I can move into that.
Okay, so the individual health identifier is a new number based on the Individual Health Identifier Act. It contains a number of pieces of information that allow it to, with appropriate legislation in place, be linked to different data items, and it allows it to be used across the health system. Very specifically, health system, not the public or private healthcare system. It won't be retrofitted into every system that exists within health. What will happen over the years to come is the individual health identifier will become the standard number to be used in those systems. So the maternity and newborn system that Richard mentioned, it is part of the contract that the IHI will be in there. It will be put into patient administration systems. It will start to appear on the eReferral letter and in GP systems. And therefore over time become the single identifier across health. With luck, and it is luck, we discovered that the NHS has allocated 60 million NHS numbers to the Republic of Ireland some years ago. We've been able to take those 60 million numbers, and that means that we can actually use the individual health identifier if patients are receiving or having care in any way in the north, in Wales, in Scotland, and England. It allows us to have a joined up system. Behind the individual health identifier, though, in a codified way, is a number that can also be used with the patient's consent in other jurisdictions across Europe. We're actually future-proofing the number to allow it to be used in a wider situation, but specifically to health across the system.
Okay, great, thank you. We have a comment or a question here from Mairead Harding, and I'll direct this to Professor Greene first. She specifically mentioned Professor Greene's comment. She wants to know about that we should have a think about what it is we want coming out of the, I presume she means out of this whole process, not what we can get because of what's already available. And she just wants your kind of comment or thoughts around that.
Well, I suppose one of the things that fascinates me when you talk to clinicians, and when I say clinicians, I mean that in the broader sense, nurses, midwives, healthcare professionals, and all that. But when everybody actually is interested in the electronic health ideal in terms of the data we can get out. So you know, we all want to do our audits, we all want to do this, that, and the other, and we all want to know stuff. But actually, if we haven't given some thought to how we collect the clinical information, and that we're collecting it in the simplest and most basic ways, what we'll find is that we'll actually tie ourselves into having definitions. The data will be in there because of a definition of what we want out, instead of raw data. So if you take in maternity care, if we put in a diagnosis for preterm labour as 37 completed weeks, and so we want everything that's under that or over it. Well, some people will take 37 weeks and 1 day, and some people will take 36 weeks and 6 days, and this kind of stuff. Whereas if we actually put in the data in its purest form in terms of the number of days, weeks and days that mother is pregnant, and we can look at right across that data set, we can then set the definition subsequently to decide what we're looking at. So that's what I'm talking about, that we don't want to set the system up to meet definitions that people have in their heads today. We actually need to set it up so that we can get the simplest appropriate information in. It has to be clinically relevant. It's very hard to set it up to do all of to set up what might be coming in a research project in 10 years' time. But I think it needs thought at that level.
Great. And Richard Corbridge, do you want to comment on that as well?
Yeah, I think what we've tried to make sure we've done with things like the CCIO Council is make sure that what we're doing is clinically led. And again, learning from other jurisdictions who've perhaps done this as an IT-led program, what we're trying to make sure is that the programs that are coming out are based on what the clinicians in Ireland are saying are needed first. So making sure that eReferrals, eDischarge are things that were quick wins, but things that were defined by clinicians as being useful to have. The prescribing pilots defined by clinicians as something that they really want Ireland to look at first. The CCIO Council itself is now 150 people strong. That's a big body of people to be able to keep IT people, for want of a better way of putting it, on the straight and narrow. We talk about eHealth Ireland by the time we get to 2020 not being led by a CIO, but being led by a clinician. And that to me is really important, that we start to actually make sure that this is about changing business practice, changing the way we deliver our business, not about implementing IT projects and programs.
Okay, great. Thanks very much. One issue that I suppose is kind of in the back of my mind as you were going through your presentation was that about ethics. And again, coming from the research, embedding a clinical trial, coming from that point of view, do you think that this sort of new structure is going to require a new structure for ethics, but not just obtaining patient consent, but around, so where do you go if you want to use the data obtained from this? Or do you have any thoughts about that? I might direct that to Richard Corbridge first of all.
Yeah, I think when you look at the NHS as a system, as an example, the National Institute for Health Research was absolutely able to take the benefit of having electronic health records and information in that space, apply a different ethics process to it, and move more quickly towards ethics approval and patients recruited into trials. And therefore, I would suggest that probably the same will come as we start to understand better what an electronic health record does in Ireland, how ethics are delivered, and how they're sought would be a different way of handling that.
Oh, great, thanks. And Richard Greene?
Yeah, I mean, I think inevitably it's going to continue to be a requirement, and it will be more so in some things than other. But I do think that we probably do need to move towards. Hopefully, a lot of these projects will end up that we're pretty well national in terms of how the information is stored, etc. And access will be national, and therefore I think we need to move towards a national ethics approach. Brilliant.
Thanks very much to both Richards this afternoon. I think that concludes our webinar as we finished the questions from all our participants online. Again, Richard Corbridge and Richard Greene, your input has been invaluable, and I think the recording of this webinar is going to go down really well with the HRB TMRN memberships, our members nationally. So thanks so much for joining us today. And just before we wrap up, we just wanted to invite everybody to visit our website. We have some upcoming and exciting events planned, such as a realist review workshop with our colleague, Professor Ailish McAuliffe in UCD Centre for Global Health. That's happening this month. We also have good clinical practice training in NUI Galway in March, as well as systematic review training in NUI Galway in April. And I do welcome you to keep an eye on our website, as we do have a lot of very exciting events planned for 2016. So again, just to finish up, Richard Greene, Richard Corbridge, thank you so much for joining us this afternoon.
You're welcome.
Thanks. Talk to you soon.
Thank you very much. Goodbye.
Bye.